Ajay Haryani is a regional medical director at Galileo. He's equal parts empathetic, tactical, a whole lot of clinician sprinkled in with even more of an operator lens. It's amazing to see how he can straddle so many dimensions of strategy.
Ajay shares his playbook with us for how they use SMS at Galileo as a central part of executing on their care delivery model, which is great because Ajay is also one of the fastest texters that I know when I need something.
Yeah, I think for folks that are building in the value-based care model or anyone who's trying to think through their SMS strategy, and I guess anybody who's in the art of perfecting async and making it feel intimate, his words.
Not that kind of intimate. Not that kind of intimate.
He said it, not us. All right. I think you'll get a lot of value from this conversation and walk away with several good tips to make it successful in your org.
Let's get into it.
Let's do it.
All right. Ajay, it's so awesome to have you here. Thanks for joining us.
Yeah.
We spent a lot of time trying to understand what your company does and what you do. And come to some realizations that it's very unique. And in talking to you, we got to jam out on one very small but very big part of your business, which is the role of SMS in how you deliver care at Galileo. So I'm stoked to get into the weeds with that with you today. I also just want to preface it that I did some crowdsourcing of questions from other value-based care operators throughout this, and we'll be peppering those in. So be ready for some hard-hitting ops questions from the universe.
Let's do it.
I'm here to prevent more people from sending me bad SMS text messages.
Amazing. Well, Ajay, maybe you can start us off here by giving us like 1,000-foot view, explaining what Galileo does, then maybe like a 500-foot view, and then a 100-foot view, and then your role, and give us an understanding of all these moving parts.
Yeah, absolutely. So, like pie in the sky, Galileo is a full stack primary care practice. We provide primary care services across the entire patient population through a variety of clinical touch points, both virtually and in person across the full spectrum. And then bringing that down to the next level, we've got two sides of the organization. We have a kind of digital first, virtual only side of the organization that serves, you can think of kind of the 80% healthier side of the population. And then the side of the company that I do most of my work on, which is the complex care delivery organization that partners through value-based care contracts with Medicare and Medicaid organizations. And then zooming into my specific role here is I am a regional medical director. I oversee our 4 complex care markets. So I have four clinical leaders under me and then all of our frontline providers under them. I'm responsible for market performance and making sure we're delivering on the excellent care that we promise.
Let's stay on the whole field-based side of your business and your role. Maybe you can share a little bit more about kind of what you've learned on how to build a very successful, efficient, high-functioning field-based team.
Yeah.
Also, what do the field-based teams do? Like for my context,
yeah,
right? Like,
sure.
Are they going every day, or what do they actually do? Are they doing like complex visits? Are they doing wellness visits? Like, I'm curious. Like, what do the field teams actually do?
They do everything. They do everything.
Other than everything.
That's the answer to everything.
We do. We do a little bit of everything. I know we've got a variety of folks out in the field, right? So we've got kind of purely, like classic primary care clinician types that are out doing home visits. We also see patients out of mobile clinics that we drive around into patient communities. And then, they're also doing virtual care stuff, which is technically not field-based. But we also have a kind of community health worker phenotype called a health advocate that we pair with each of those providers that are out in the field together. Sometimes those health advocates are deployed into homes alone or are bringing in the provider through a virtual visit. We have also kind of field-based behavioral health resources and social work resources that are out there kind of tackling those problems as well. So the variety of services is pretty wide. And then they're doing, they're seeing patients on the cadence that's needed to keep these folks healthy and keep them at home. So higher acuity patients might be seen, every month, maybe every 2 months. Lower acuity patients a bit wider out than that. And we try to kind of provide the right provider type and resource for a given moment. So they're doing that variety, and they're also doing a mix of different types of care. So they're doing kind of primary care, what we call proactive care, thinking about, routine chronic disease management, preventative health services, making sure folks are getting their colonoscopies, flu shots, COVID shots, things like that. And then we also have a field component to our urgent care and reactive care that are, responding to acute incidents, acute exacerbations of chronic disease, things that, if not stabilized, will end up with folks in the hospital. So the care model kind of serves both sides of that.
And how far, if I'm a physician working for Galileo, how much of my time in a given week do I know in advance versus things that change and come up on the fly? Because I assume the urgent stuff, obviously you can't plan for, but you need some slack to handle that, right? So how much is pre-planned versus sort of ad hoc?
It's pretty templated, I would say. And this is one of the key components, I would say, in managing a field-based team, especially a field-based team that is doing a number of different activities, is that you really have to provide them a fair amount of structure to feel comfortable doing this type of work, right? If you are kind of out in the field every day, running around between patient homes, there has to be some level of consistency week to week in what you're doing. Otherwise, this quickly becomes a very exhausting activity. So most of our providers have a pretty good sense of the days that they're going to be in the field seeing patients, have a pretty good sense of what areas they will be in on different days, although there's a little bit of flexibility there, and what days they're going to be at home doing care coordination work or at home doing virtual visits while that health advocate's in the field. So there's some slack built in. There's a little more slack built into the health advocate role because they're more of the deployable resource when we think about kind of urgent care activities. But it's, as far as field teams go, it's an important part of kind of maintaining that, I would say. And that, to answer the kind of first answer to that question, Danielle, is I think one of the things I learned up front was that you have to really respect the emotional weight and the physical weight of this work. It is one of the most exhausting types of kind of direct service and work that exists. It's kind of being on the road for entire days at a time, seeing patients. In our more rural markets, right, that's hours of drive time. And in more urban markets, it might be, public transport or ride share or things like that, or driving as well. And ignoring that and acting like that's not a part of what's weighing on people, I think only increases burnout. So being able to just support that mentally and physically and talk about it and bring it into the conversation is kind of number one. Number two, I would say, is you have to get your whole team out into the field, which is that your ops folks have to get into the field and do shadowing. Even, your providers are obviously going to be out there, but even folks who I consider kind of virtual care providers who are not typically in the field, I really try to get those folks out into the field. Folks that are doing more clerical work at Galileo, still trying to get them out into the field. It's a very unique feeling. And it is a very difficult thing to describe without just getting folks out there to actually see what it feels like. So one of the examples is we got our scheduling team out to go shadow visits for a couple of weeks because they're the ones mapping folks on a map and trying to optimize for geo efficiency, also trying to get new folks in, acute visits in. And so having them be out there so they can really feel what it likes to take 2 or 3 trains or be on the road for hours a day was a super helpful thing and something that we try to keep up throughout the organization. Those are probably the main things that come to mind as far as what I've learned over the past couple of years in managing field teams.
Any other core parts of managing the team that are really essential for making it high functioning and for folks out there that are also trying to build a field-based team? Any secret sauce or learnings you can share to make it better?
Yeah, I guess, the last thing I'll say is that you have to be, and we can get a little more granular about what this means, because it's a floaty word I'm about to use, but you have to be really extra intentional about culture in a decentralized team like this, because a lot of providers are used to working in a clinic-based setting where actually the sitting in the charting room together, typing your notes is kind of a natural, instigator of building camaraderie and supporting each other so they can bounce clinical things off each other. And it helps share the weight of the work that you're doing. But when you've got field teams who are in the field most days of the week, you have to be a lot more intentional and structured about what in-person time you're going to spend. So we have built in weekly in-person time for each of our markets to spend together. And that's a whole morning dedicated towards team meetings. We'll do lunch together. We'll do interdisciplinary case review together. So we're talking about our most difficult patients in person together and not necessarily all spread apart on virtual or phone. And then just, a lot of intention towards making sure we have those like social events on the calendar and keeping an extra eye on folks to make sure that they're doing okay. Because a lot of those signals that you pick up when you work in the same office as somebody, you kind of miss. So that's, that of course is prevalent in like the virtual, more remote world that we live in now, but just a little bit of weight added when it's care teams, I think, given the work that they're doing.
Yeah. One thing I was just personally curious around in that those long drives that you have through maybe more rural parts, like what do you do on those car rides? Like what's your go-to activity on a 3-hour car ride?
Yeah, I I try to do as many patient calls as I can during those times, especially if it's folks that I know want to chat a lot, then I'll like work those in during the car rides, the best that I can. And sometimes we may have two folks driving together, in which case one can kind of, crush notes on the side on their hotspot at the same time. Or as a backup to that, it's like good decompression time between visits, kind of reflect on the visits I've had that day, and what decisions I want to make. So it's a whole mix of things and depends on the day.
You need car sick avoidant doctors basically to do that. I would just upchuck trying to look at a screen for 3 hours in a car. Sure. And it's the best way, like, for you to reach those patients. Is it like you're calling them and you already have a relationship with them? Is it like, this is sort of a segue, I think, to the SMS stuff, which is like when you need how do you think about, because it sounds like you're calling patients in the car ride sometimes, you're texting them about certain things at other times. Like, how do you choose which medium you're picking to communicate which type of information?
Yeah, it's, during our initial visit with the patient, we have a really explicit conversation around communication preferences. And that's not only preferences of the patient, but especially in the geriatric population, it's getting a hold of like, who are the main stakeholders in their life, right? So like, who's the caregiver, who's the son that makes the decisions, or like the daughter that's really involved, and getting their phone numbers as well, and getting their preferences for communication down. And then we use those to guide a lot of our care, right? So if it's, and I guess the other layer on top of that, or the other axis, is the type of conversation that I'm looking to have with that patient, right? So if I'm calling a patient to give them an update and they have abnormal lab results and I'm going to have to prescribe a medication, right? That's a synchronous conversation. That's a phone call. That's not something I'm going to, disclose over text message, because there's going to be questions. You don't know what that patient is doing at the moment that you text them. And it requires like a little bit of emotional holding and discomfort there to work through that moment sometimes. If I'm using that though as just a check-in to say like, hey, you missed your appointment, is everything okay? That's great for SMS, because you can get that anytime, you can respond to it anytime. It unlocks, and we'll talk more about what I think the like benefits of SMS are. But I think those two things together, communication preferences and then the content of the conversation that we're looking to have in that moment, really determine what route we're going to take for a given patient.
Yeah. And in those two examples that you gave are more outbound side of SMS, where you're kind of the one determining whether or not you'd reach out via SMS or a call. It's not the inbound side. And we'll get into that too. But you alluded to a point there, which was what makes SMS so impactful. So maybe you could unpack that a bit for us and tell us your take on why you think it's so great.
Yeah, I think that there's a few things that are really special about kind of unlocking both async care, but specifically SMS in this case. Number one, and the kind of baseline that I think everybody knows and will call out, is that SMS is just very prevalent today, right? Lots and lots of folks have access to it. More senior citizens than anybody would ever guess, like pretty effectively use SMS. And also their caregivers, as I mentioned, are heavily on it all day. It is, if you ask patients, especially younger patients, if you ask them, or caregivers, what is your number one communication preference? SMS is almost always at the top of that list. So ignoring that is to ignore, patient-centric care in one of its most core ways, right? How would you like to talk to me is such a basic fundamental question. That's number one. Number two, though, is that I think it really reverses this power dynamic that we've set up in the healthcare system. If you think about traditional care, it is built around the question of, when can the provider see you? And we're going to give you a 15-minute slot for you to be in one very specific location for that amount of time. And they're probably going to be late. And that's the only slot that you get to have, a conversation with your provider. And if you can't make it there, you don't deserve care, is what we're telling those folks. And SMS is the entire opposite of that, right? Which is, I'm giving you the opportunity to text me whenever you have time to. And I'm saying that I will be responsible for maintaining and monitoring and being there and kind of responsive in that way when you do reach out to me. And I think that just unlocks so much ability to move care forward. I give the example of when I was working at the county hospital in SF. This was like the number one ask of all of the residents in the clinic was like, why can't we just text our patients when we know that this is how they want to communicate? And then the last thing I'll say that I think is really powerful is that it unlocks time in the care relationship. In that one of the constraints of visit-based medicine is that you have these very short time intervals to discuss, to give information, to get information, to process, and then make decisions, right? These are like 4 independent forms of communication that each need space and time. And when you see a provider for 15 minutes every 3 months, this happens in these hyper small chunks, and it's not really good decision making. It can just be really tough. And this again kind of flips that on its head, which is if you unlock care outside of the visits and do this asynchronously, you have time to process in between. The patient can come back to you with a question 20 minutes after the visit ends, right? Where typically they leave the door and they're in the parking lot and they're like, oh, I meant to ask about this and this. And now they can just send that text message, right? Or they can send it whenever it comes to their mind, whenever they get off work, thinking especially about marginalized populations where they might be working multiple jobs, or they may not have transportation access, things that are, really obvious barriers to them being able to kind of step into care in this way. This is both that kind of convenience play of the first patient and a pure access play for that second patient, to be able to provide them care.
It's pretty interesting also thinking about, in other countries, WhatsApp is such a common communication channel between docs and patients. And, just anecdotally, it's just a totally different means, first of all, means of running your business too, right? Because if you're a doc communicating probably through SMS, there are lines you got to figure out between when do you need to come in for a visit? When do you need to pay for a visit? When do you not, who's answering the message, blah, blah, blah. So it's, you can kind of see analogs in other countries for what this looks like.
Mm-hmm.
So one question I wanted to just follow up with, there's this debate right now sort of flowing out of that because hospitals are charging for MyChart messaging now, right? Which I think of as flowing out of this a little bit, right? You guys are in value-based care arrangements for the most part. Yep. So I'm curious, how, first of all, what your thoughts are on billing for MyChart messaging, because I can actually see both sides of this coin, and then also on the flip side, how you think about the value, what you should be quote unquote charging or staffing resources to answering texts versus in-person messages.
Yeah, it's the charging for MyChart messages thing is a perfect example of incentives playing out in a pretty rigid system that does not do any new service design. And when you put all that together, this is what you get, right? So you've got the health system who has really no service built to manage inbound in a pretty effective way, right? Horrible phone trees that everybody gets lost in and hangs up in. And we have got inbound epic messages that are mostly falling on provider shoulders, but sometimes getting filtered by like medical assistants and things like that. But really no intentional service design around how do we manage the inbound? How do we float, the real bigger problems to providers and the smaller problems to front desk and scheduling? When you don't do any of that work, all of the work falls on the providers. And then you end up with this kind of conclusion of, well, if I'm taking up my provider's time, I need to bill for it because the opportunity cost there is a fee for service visit. And so it is understandable why people got there. But it's, in my mind, kind of philosophically the wrong answer to the question, which is that I think that you can still think about staffing models within health systems, even within a fee-for-service environment, where you are actually attacking all of this inbound a little bit more effectively. It's easy to say from the value-based care world, right? Where I get to kind of live in a world where I can choose my touch points and like my incentives are, aligned in those ways. But yeah, I think it's tough. And then I think you end up increasing activation energy for folks to reach out to their providers. And like, if anything, this is the last thing I'll say about this for a second. One of the things I think the most about as a primary care provider is, will my patient reach out to me in a time of need? And that is one of the most important questions. It's so much more important than like even them showing up for their routine visit. Because like the moments of vulnerability and the moments of acute sickness are some of the most dangerous moments. And these are also the moments that demonstrate the highest degree of trust. And you're taking the easiest way they could reach out to you and they could express their need to you and then putting a fee on it. And that feels so wrong to me. And which is why I think it's tough. But again, I understand the mechanics behind it and why they go there. And essentially it's kind of as just like a behavioral stick to try to get people to do it less. But that's the wrong philosophy from my side.
Just like riffing on something you said earlier around the triaging trees, right?
Yeah.
That hospitals don't have. I mean, I was just talking to a friend who works at Kaiser, and her biggest complaint is that there aren't good systems of triaging the inbox for severity, right? Mm-hmm. And I think what you said totally resonates. Curious, like how either like the tech stack or the process that you guys have implemented to deal with inbound messaging to figure out triaging and all that kind of stuff.
Yeah. No, this is one of the most important parts of running a service like this, right? Because if you are opening up this channel of inbound and saying you can text me, then like I think that it's your duty at that point to both be responsive, but also be monitoring for acuity and for issues that come up. And I'll say of all the texts we get, probably 20 to 30% of them are acute clinical symptoms. A lot of folks will end up calling, but folks will text in with issues. So it's, how do you correctly identify those 30% and get them floated up to the right person? So we've built triage protocols that, the staff that monitor our inbound text 24/7 follow. And we've had to kind of coach and run workshops on this and make sure everyone feels really comfortable with it on how to identify this question of what is clinical. And taking those moments out of their hands and handing them off to either, a triage RN is somebody who can then make another step, and or a provider if it's something that needs to actually be addressed or digging a little bit deeper into. And so we've built protocols around the different types of things that can come through. And most things do fall into the, 4 or 5 buckets. It's, a new symptom, sometimes of a value. Someone might send in like a glucose reading and be like, hey, doc, my glucose is like 54. Should I do something about that? That needs to be escalated emergently, right? Medication refills, which is what are urgent and what are not urgent. What could just go documented in the chart for the provider to address with like a 24-hour SLA versus what is like a 4-hour SLA around that medication refill. And so we've had to create trees here and then kind of coach around them to make sure that we're getting the right information floated to the right folks.
If a patient sends a meme in, which of the 5 does it fall in? Is this a six that breaks the whole process? Or do you send them for an assessment?
There's a sixth one that goes to you, Nikhil, and then you get to give the meme assessment on how much trouble that patient it is in, and then let us know at Galileo, and we'll take it from there.
Perfect. I know my role.
It's the ops in me is like already imagining lots of different trees in the background that I'm following on some sort of flowchart software, and it's terrifying to think of. But at a very high level, what I'm gathering from your explanation is that SLAs are tied towards the bucket that person has diagnosed. Maybe diagnosing is not the right word, but categorized that within those master buckets. This one. So is that kind of a fair assessment? SLAs are relative to the thing that they're identifying?
Just to riff off that point for a second, this seems like why having a longitudinal record and history with this person matters, right? Because if you're in a fee-for-service environment and you keep switching the person you're talking to, then you don't have the context of knowing how important this singular message is.
Right.
Yeah, I think that is right. Although, there's a large aspect of triage that is like relatively commoditized, I would say. And like once you've been practicing as a clinician for some time, like this function has existed for years, right? There's like triage RN lines. The VA has had a pretty good one for many, many years. So this has existed. There's the Briggs book is a classic book that folks buy. You can Google it, and it gives like classic triage pathways for different symptoms that come in. So the function has existed and is relatively robust and easy to follow. But you do, I think, in going back to your question, Danielle, there's an SLA around laying eyes on the text, which needs to be really fast for everybody because you have to figure out what's important and not. And then from there, yes, then the next round of kind of SLAs is determined by the content of the message. And then if that goes down the clinical path, they have their own set of getting back to the patient and, how quick follow-up needs to be and things like that. And then if it's a non-clinical issue, when that's going to be reviewed next kind of by the care team for action.
Is this like in software somewhere, or is this like people just are trained and they just, know this?
Yeah, it's a bit of both. We've got some of it built into the software, but, a lot of it is still like human process, and kind of coaching and training around this. Just because, there's some aspects of the software that can help identify things that might be symptom focused. And, so there's like a little bit of light automation there. But there's enough nuance here that like it still ends up being a lot of kind of, human process driven work.
So you have some sort of software that can help mildly identify potentially some of it. And then you've got training. One thing that I would be curious around is if you have a really rigorous QA process and if you can touch on that at all.
Yeah, absolutely. Right. Because in this case, we've got to take this like aspect of patient safety very seriously. And it's the bar has to be really high there for kind of no like near miss events here. So we do have a pretty rigorous QA process. We have weekly meetings that are just reviewing issues that we've had in this escalation process. And we're kind of constantly going back through, constantly giving feedback to frontline staff and to the clinical teams on what we need to do there. And we have to create a culture of like everybody being able to escalate these issues because they touch everybody, right? You can imagine that the workforce that monitors the text messages is a pretty large workforce because it's monitoring 24/7. And so we've got all of those different folks. Then we've got all the clinical folks that might be getting the triage on one side. And then if something gets mistriaged and goes in the wrong direction and ends up in somebody else's lap, we've got to empower that person to be like, hey, in case this happens, this is how you get it to the right person. And this is how you escalate that case. So yeah, pretty rigorous, like internal processes, both culturally and tactically on a weekly basis to make sure that we are holding up high kind of quality standard there.
How many hands would you say, like, let's take an example of a text that comes in. Could you maybe walk us through the different teams that are all touching that one text message?
Yeah. So the first team that touches the text messages is we call them patient support associates or PSAs. They do a variety of tasks for Galileo. They're like a bit of a virtual workforce that support kind of a lot of, cloud-based care coordination work, you could call it. And one of the things that they do is monitor our inbound text. So they're the first person to lay eyes on it and to make that kind of initial triage decision. And if they have questions about that decision, they've got folks to escalate to that we can kind of pull in. If it gets determined to be a clinical decision, it'll get handed off to somebody who can do a more effective clinical triage. This is usually a triage nurse who can then kind of do the next pass and determine if this is something that truly needs to be addressed by a provider who's on call right now, or whether this can be wait for the primary care team to address it kind of within 24 hours about. The non-clinical stuff usually gets documented and handed back off to the care team directly from there. So not too many different teams, although there can be different people playing that role at different times, given that some of these teams are kind of quite large there.
Well, it sounds like you've got this pretty down pat now. Maybe you could give us a sense for how it used to look and the story arc of how it got here, especially for folks who are trying to build the V1 of their SMS or just trying to get this off the ground that don't have several layers of triage or specialties even within there. I think it could be helpful to kind of rewind and give us a sense for how it started.
Yeah. It followed kind of a classic arc that I think happens in a lot of startups with regards to services, is the kind of transition from being more decentralized and owned by the particular market or field team, and then over time, as needing to scale, that getting centralized and needing to build a bit more of kind of robust process around it. And there's like interesting trade-offs that kind of come around there. So initially, these would be monitored by the either the care teams or the kind of local operations folks for a particular market. And so they would keep an eye on text messages, especially throughout the day, throughout business hours, and they would be the ones to kind of route and escalate as needed. And you can imagine a really tight feedback loop, right? Between the local ops and the local care teams, and local care teams being very in tune with everything that's happening with their patients in a way that's like extraordinary and kind of unheard of in a lot of the healthcare system. And those care teams being really involved in, I can just hop in and respond here. It develops a really kind of intimate human connection with that patient through SMS, which I think is like not, 10 years ago, I'm not sure I would be lecturing and being like, the way to intimacy is through SMS. But it unlocks this sense of really being taken care of. That's pretty special. So I would say that's how this started off. And that's probably the easiest way, I would say, to get something like this off the ground, at least small scale, is thinking about folks who are close to the care, also kind of monitoring and being able to keep track of things. But then, over time, those care teams need to be focusing on the field-based work that they're doing, right? And they can't be being pulled away into other tasks that are coming up. And similarly, those local ops folks have to be supporting those care team members that are out in the field and may not be, best utilized by monitoring something that could be monitored by a virtual team that is not locally tied. And so over time, then now we've kind of more robustly established this now as being monitored by that central team. And then, of course, the challenges there are you've now put another layer of communication between the patient and the care team. And how do you ensure that there's like really good communication and those handoffs go well?
Is there something that, as you look back on, some symptoms or signs that you knew it was time to move to a more centralized model?
I think one of the symptoms that you start to hear in that is that like everyone feels really busy all the time, but they can't totally pinpoint what's keeping them busy. And it's like, oh, you're spread across way too many different activities and you're in reactive mode all day putting things out, and we need to streamline this work a little bit more. So it was one of the things that we had kind of picked up on and one of the reasons why we centralized it. Similar happens with scheduling often, I think, in a lot of organizations where scheduling starts in the field and it starts with the care team, especially when panels are small. But as you get bigger and scale, like you has to become kind of a centralized process that you scale across the org.
When you do outreach to patients, like from your end, how do you decide when it's coming from the doc who has the direct relationship with the patient from maybe a more centralized patient assistance team? How do you like figure out what level of personalization? Also, just like if you've seen different response rates with different levels of personalization, like how do you pick and choose which ones, like how to do it?
Yeah, it's a tricky balance, right? Because you know that patients and people in general, like, will feel more connected to if they feel like they are speaking to a particular person, whether that's a particular provider or their primary care provider. But at the same time, wanting to build trust with the entire organization and with the brand of your organization, right? Which is that, you have a care team at Galileo or at any, kind of virtual care based company who I think thinks about this a lot, especially doing async care. And so I think, a good amount of communication we try to word as kind of from your Galileo care team, from like the folks that are looking out for you is kind of the energy behind that. We do, in the cases where, there's a particular thing you might be following up on or a particular thing you might be asking. Even in those cases, I would say we try to keep it coming from a centralized source and kind of reference that provider to be like, oh, hey, Dr. Haryani was like curious about this thing. Can you send this over? Can you send this form over whenever you have a chance to? So there's a personalization aspect to it, but you don't want to be kind of duping patients into thinking they're texting somebody back who they're not. So I think there's a level of honesty there, which is that and this is something we explain in all of our initial visits, which is like, there's a whole care team. There's a whole bunch of folks who all know about you because they can see your medical record and, they know the things that matter to you, and they want to help you. So if I'm out seeing patients, they're there to help you, right? There's a way to frame this that I think feels good to patients. But then kind of instilling that team mindset throughout and leaning on that, I think is most of the time how we would do it.
I have a bit of a question around that specific example that you mentioned, which was we needed like follow up from you, basically like, hey, can you give us a call at your earliest convenience? In my head, that translates to a ticket or some sort of open interaction or an open thing that needs to be closed out. Who's responsible for chasing down that patient and closing the loop on something you've opened up that then you need something done from their end? Does that make sense?
I think that the way that we mostly approach this is that you only really open up tickets or text somebody about something that you're comfortable receiving their response within the SLAs that we described, right?
Oh, got it.
Right. So if you are like, hey, can you send us this form? We just need to get this filled out. Take a picture of it and send it to me, or send me a picture of, the medication you had a question on, but it's not an urgent issue. You're cool with that coming back in through the flow that I mentioned, right? Which is that comes in, that patient support associate will see it, we'll document it in the chart, and then you can get back to it there. So if you were texting about, if you needed information back with that level of kind of acuity and concern, you're calling a patient is what I would say is really how that ends up. And you're calling them, and if they don't pick up, you're texting them to say, hey, I really need you to call me. Do you have 5 minutes to call me back? And then they'll call back and get transferred to you and can kind of have that conversation. So there is some bounds around, the amount of acuity that you might be wanting to address over text message before moving to synchronous. And that's the math that I would say most people do.
Yeah, and that tracks with your earlier framework of content and communication preferences. The different content warrants different ways of addressing them. And communication preferences obviously play a role in how they might respond better. Do you have like internal data on what communication channels are most used, out of curiosity?
Oh, that's a good question. I don't have this actual number off the top of my head. I would probably say the majority of our below 65 population is comfortable and prefers SMS, I would say. And let's say if I was just guessing, 40 to 50% of our seniors might be comfortable with. I don't know if it would be their number one, but they would see it and respond to it, as needed, especially if they aren't able to kind of make it to the phone at a given time. Those are guesses, though.
Yeah.
One thing I'll just say, this is not really a question, but more just an idle thought from my side. The thing that I always wish existed more in healthcare was group chats in some capacity, right? Like group chats with all of your care team at once, or group chats with, my doctor and my insurance provider are fighting and I want to just get a group chat going with them to hash this out. And one of the things that always has annoyed me, especially with the SMS channel, is that it is nearly impossible to do group chats versus it is, if within your app or within your EMR ecosystem, you can set up group chats and all this kind of stuff. So this is not really a question. It's more just like an observation that, like, I wish there were more group chats in this kind of industry. That's my rant, my soapbox.
Yeah, but I do this in email all the time. And so we can take everything we just had about SMS and what that unlocks, and you can transfer it to the email world where, most specialists, most providers, most care managers at insurance companies are on email. And I will wrangle people down and be like, hey, I'll call the specialist office and get people on an email thread, especially for my sicker patients. And I will put their 4 specialists and the care manager on that thread. And then every time they hit the hospital, I'm like, hey, what's going on? Let's get post-discharge appointments. And like, who has their eyes on this person? For some of our sickest patients, like that level of coordination is necessary. So there's, I think, like a bit of a larger thread there around what async can unlock in different environments, even on the care coordination side. But I agree. I wish it was a lot easier on the SMS side across the board.
Yeah, I also think there's probably some behind the scenes group chats going on that aren't visible to the patient, where all folks are all triaging and trying to put pieces together. And then one person's just like giving you that really synthesized response, but you're missing all the context behind the scenes of what they've talked about. That would be helpful.
This is imbalance. I want a group chat with all the patients that the doctor sees so I can roast them too. No, yeah. I'm just kidding.
When it comes to the actual SMS, I think we've skirted around the actual text content, and so much of SMS can feel so automated, and like 90% of my interactions with healthcare systems and SMS are reminders or really generic things. Do you have any tips around like small nuanced ways you can actually sound like a human when you're writing an SMS?
I think like funny little things that make a really big difference are like a greeting, like a hi, or hello, or like a hi, ideally person name if possible. And just making things a little more conversational, right?
Yeah, it's very Swiss Army knife of a tool here it checks off a lot of boxes, and then there's a lot of just good practices and tooling internally that you've built to make sure that you're not missing anything and that you're handling it with the right level of clinical or non-clinical observation and so on. So it sounds like much more of an operations challenge than I was anticipating, honestly, because you've opened up the floodgates here towards anything under the sun, and you have to be somewhat reactive all the time towards what's going to come inside your inbox.
Yeah.
Were you always 24/7?
Yeah, so we actually, I mentioned the virtual care arm of Galileo that kind of operates adjacent to the complex care work that we do. The care that they deliver is primarily through the Galileo app, and they do 24/7 async care through the app. So that part of Galileo was actually built before we launched the complex care arm. So I like to think of our complex care delivery org as kind of built on the bones of 24/7 virtual async care, and then deploying, high intensity resources on top of that for the folks who need it.
Got it. So you had that infrastructure in place.
Mm-hmm. Right.
Yeah, that's
the
important.
Infrastructure and the kind of the mentality around that, and things like that. Exactly.
Yeah. We're coming up on our time here. One thing that folks really craved some information around and data points around was how you measure success and how you define value in the SMS domain. Can you shed light on that?
So I think that of three different kind of buckets of value when it comes to SMS and kind of thinking about measuring that within Galileo. Number one, and most importantly, is, the patient safety component and making sure that we're living up to our kind of promise of high clinical care quality. Number two is patient experience. And then number three is a bit of an internal kind of utilization metric around, do we think that we're utilizing SMS as much as we should be within our care model? On number one, on the patient safety side, is a lot of that triage protocol that we talked about, which is we need to feel really confident that clinical issues are not going to fall through the cracks when they're coming through the doors, and that they're getting to the right folks within the right amount of time. And so we do measure that. We measure, as far as the amount of time it takes for folks to respond to a message, how long it takes for the clinical team to get involved, and then how long it takes to be able to kind of resolve that issue. And then in addition to that, we measure, are we avoiding ED visits by those interactions as well. On the patient experience side, I think the main thing to measure there is responsiveness, which is, how fast are you looking at the message and getting back to the patient with a meaningful kind of response there, right? So you can think about the first tier of that, which is acknowledging the message, which needs to happen very, very quickly. And then the second tier of that, which is providing kind of meaningful information, whether it is that clinical triage or an answer to the question that they had. If they're asking when their next appointment is, something like that, right? Did we actually answer the question? And then the third aspect is, I mentioned the idea of utilization here because SMS is a new form of care delivery. And anytime you're implementing something that your team members haven't necessarily been trained on, there, in my mind, is kind of an expectation that it's going to be underutilized for the amount of value that it can provide. So I think about, how many outbound texts are we sending over the number of patients that we think are text capable that want to text. I think about inbound to outbound ratio of text messages. And, because that's a good sense of, are we replying to our patients on time, and are we kind of matching them in our ability to provide these conversations? And are we texting patients who want to be texted, right? If we're sending a ton of outbound that's not getting any response to it, then I think we should think a bit about whether we're using that channel kind of accurately. So those are some of the main things I think about when it comes to value of SMS here.
It reminds me a lot. There's some analogies here to the chat functionality that's, I think, pretty underutilized in healthcare because it's not always a web-based experience. But if you look at how you were to build up chat on any other kind of maybe consumer-based company, the speed and quality of response are two of the biggest reasons why people will jump off of chat. But SMS to me feels like a very unique way to kind of take away some of what doesn't work in chat, which is that it's web-based or it's very easy to X out of a browser, whereas SMS kind of follows you throughout the day, but still has that sense of immediacy. So I think folks that are leveraging chat are trying to, this for me has been a new way to look at how we can bring almost like that chat-like mentality, but into the SMS framework and look at SMS as an immediate response, not just this async answer whenever thing. Like, no, you got to be fast and you got to be accurate in the way you respond. That was a big takeaway for me in this conversation.
Yeah, I think it is really interesting, right? It takes down barriers that are existing in chat. It puts it from the platform into the pocket in that way, yes, where they can respond when they need to. But it is, like you said, it's a lot of onus to carry as an organization to kind of open that up, especially when you are claiming to be a clinical provider and, there to support them in those ways. It can be a lot.
I am very, very impressed with what you all have built. It's no small feat operationally. And it's really amazing.
You got any SMS hot takes?
Me? SMS hot takes?
When to send messages, what kind of messages to send, bad builds, good builds. Have you seen any particularly bad SMS flows without naming other companies or other industries that have used it?
I think that one of the ways to immediately recognize a bad flow, and it's so obvious on the patient side when this happens, I think, is when you get multiple folks that are jumping in on the organization side at the same time that are saying kind of conflicting things. I think it is like the biggest buzzkill when it comes to building a relationship, where like somebody says like, thank you so much, we're going to get that back to your care team. And at the same time, somebody asks you a question about the thing that you just answered. And so it's one of those patient experience things that like immediately any human touch that was created is out the window. It feels kind of uncanny and strange. Like, who am I talking to? Is it a robot? Is it multiple people? Is it my doctor? I have no idea. And I think it makes people want to immediately disengage because it starts to really lose that touch. So that's one of the things that I think it's really important to kind of protect against when you're scaling SMS from within an organization. And outside of that, no, I just think it's like a really, really powerful, wonderful tool that can have a lot of impact. I guess my hot take is what I said earlier, which is that you can build a lot of intimacy through SMS. And I think that's, I stand by it. I stand by that higher frequency of check-ins being really important.
That's going to be the show episode. How to build intimacy intimacy with SMS with Ajay.
I have one other question around just like this idea of building relationships, because you have an advantage when it comes to relationship building, which is obviously you being a very empathetic and easy to get along with person, but also that your company is so field based. So you have the real human to human connection that many virtual care companies don't have right now. And so introducing SMS actually seems a lot more impersonal from the get-go. So if you were to magically advise folks that want to bring SMS, want to bring more relationship building, but don't have that initial touch point to set the ground rules, understand, like, what would you do in that case to help set the right foundation?
Right. I think to answer that, right, you have to ask the question, what do patients actually care about? And they want their problems solved, and they want them solved quickly. And if you can do that, and you can be responsive, and you can provide high quality information like we were talking about, right, that is providing value to that patient in a much greater way than seeing them multiple weeks later for an in-person visit. A lot of the time. And of course, you have to separate things a bit here and there, right? Certain conversations are not appropriate for async at all. And you've got to know what needs to go where. But I think the hesitation there assumes in some environments that patients' priorities may not be as they actually are, which is, in-person care and human-centric care is extremely important. But there's a lot of moments in which access, convenience, and acuity or time to problem being fixed, I think would outweigh that. And so thinking about the populations you're serving, I think, is important there too.
I've tried to bring SMS in my companies, and one of the biggest challenges is like people just don't remember your phone number or just forget your existence entirely. Do you have like a something that you do in the initial visit to like make sure that's locked in? And like any good best practices around that?
Yeah, we will create the contact with the patient on their phone, and we will save it together as Galileo, your primary care office. And we will show them how to text us, or I will send them a text just from our app real quick to see it go through. And so there's a little bit of coaching there, which is you're not used to reaching out to your primary care office this way, but look at what you can do. And you have to show them a bit, because you're right. They won't just naturally start texting you. Even when I say that to patients, they look at me kind of skeptically, like, why would I do that? And so there's absolutely a little bit of coaching there. And it's from our side, making sure our texts are coming from the same number across markets, making sure it's a local number, right? Thinking about things like that to make sure that it feels trustworthy and makes sense. But using that initial in-person visit as an opportunity to build the trust and kind of connect all of those dots, I think is super powerful.
Yeah, that's been something from multiple folks that I've talked to who focus a lot on onboarding processes in virtual care. one of the biggest tips that they say is don't ever leave an onboarding call. Don't ever leave an onboarding interaction without checking off every single one of those details. So if there's an app involved, make sure that they've downloaded the app before you hang up on the call. If texting is a core part of your business, make sure you create that contact. So I think that framework and that checkpoint can be applied also virtually as well, and is just a really good reminder of those small details help extend that relationship beyond what goes on in your head. Because in startups, you're like, oh, you can text us, you can do all those things, but you just like forget that there's an actual activation moment that needs to happen. And being super explicit is such a good lesson.
Yeah. And you're entering a world of noise, right? If you start entering into SMS, and you have to be really careful to not fall into that noise. And this little creating contact, showing them, is just a little bit of creating signal within that noise in that way. And I think it's worked pretty well.
Nikhil, are you taking notes on that for when you want to pick up peeps to make sure that you set on their contact?
I'm taking notes on how to triage my inbox.
You need
story. Need someone else to do it.
I'm sure there's a lot of lessons on that we could take personally. Any thoughts here? Last things about SMS that you feel strongly about that we didn't get to?
No, I think we covered all the main things. I mean, I'm always happy to chat about this. I'm super passionate about it, and I think it's like one of the biggest care delivery unlocks of our time. So if folks are interested in it or excited about it and want to learn more, just like always happy to kind of nerd out on this together.
Amazing. What is the best way for folks to get in touch with you should they want to?
They can
text you, obviously.
I was waiting for that.
Come on, jeez, this is a layup.
We can include a little like Mike Jones moment where I drop my cell phone number at the end of your podcast. Yeah, easiest way, you can like always hit me up on Twitter at Ajay Haryani or LinkedIn. Email address as well, aharyani@galileo.care. All are great ways to get in touch and would love to chat.
Yep. Okay. Amazing. That's it on my end. Nikhil, do you got anything else you want to weave in and edit post-production?
No, that's great.